Thank you, Dr. Ahmed. Assalamu alaikum, everyone. It is an honor to give you some hints about management of osteoporosis in patients with CKD. Our talk agenda is what is osteoporosis, why osteoporosis in CKD patient is so important, how does osteoporosis happen in CKD patient, and how to diagnose, what are the options for treatment, and our take-home message. According to WHO operational definition, osteoporotic patient has bone mineral density of equal or more than 2.5 standard deviation below the normal mean. It is equal to t-score of minus 2.5 or less. The normal mean was calculated from BMD measurements in young adult white women. And this definition, as you can see, it focuses only on bone quantity and neglects anything about bone quality. But they said they aim to establish the prevalence of osteoporosis with this definition, and they stated that it shouldn't be used as the sole determinant of treatment decision. They said scores adjusted for ethnicity or race should be used, which I think hadn't been done. In 2000, the National Institute of Health defined osteoporosis as a skeletal disorder characterized by compromised bone strength, predisposing to increased fracture risk. And as you can see, the bone strength could involve both bone quantity and bone quality. And we have the clinical diagnosis of osteoporosis. So the presence of a fragility fracture, irrespective of BMD, can diagnose the patient with osteoporosis. The fragility fracture is a fracture which can happen from a fall of a standing height or less without no major trauma. It is not like a motor car accident fracture. The National Bone Health Alliance recommends that diagnosis could be made in USA using the FRAX scoring system. If the 10-year probability of major osteoporotic fracture is equal or more than 20%, or 10-year probability of hip fracture is equal or more than 3%, you could diagnose this patient with osteoporosis, even if you don't have the BMD of this patient. So why osteoporosis in CKD patient is so important? In general population, osteoporotic fracture have high burden on disability. You can see osteoporotic fracture is second to colon cancer, liver cirrhosis, diabetes, COPD. So it has a very high burden. And in patient with CKD, it is much worse. Patient with GFR less than 60 milli per minute, they have at least twice higher risk of osteoporosis. This risk increases with the decline of kidney function, ending that end-stage kidney disease patients, they have 4 to 6-fold of fracture risk compared to matched population. And when our patient fracture, they have double risk of mortality. And it is not only about the bone. In the past, we know that bone is a buffer for minerals. So bone loss will lead to accumulation of minerals to the circulation. These minerals can predispose to vascular calcification. Now, there is a growing evidence of a bone vascular axis, which is working in both directions. How does osteoporosis happen in CKD? We know that bone is a dynamic tissue undergoing constant remodeling throughout lifespan. So when you are young and healthy, there is a balance between bone resorption and bone formation. This ends up with healthy and normal bone. But when you have imbalance between osteoporosis, imbalance between bone resorption and bone formation, you would end up with osteoporosis. You could have either very high bone resorption. If you have high turnover, you could have very high bone resorption, or you could have low turnover, which ended with very low bone formation. As Dr. Mohamed said in his lecture, we have the turnover, mineralization, and volume. So we have two categories of turnover, which is high turnover, at least two categories, and low turnover. The pathogenesis of osteoporosis in CKD patient is complex because CKD patients, they have many risk factors for osteoporosis, beginning with the disturbing gonadal hormones. They have a milieu of uremic toxins and metabolic acidosis. The use of medication in those patients, many medication can predispose to osteoporosis, and we use them like frequently in CKD patient, like BBI, like warfarin, diuretics, like immune suppressive in transplant kidney patient. And on one side, There are many factors which could lead to low turnover bone disease, beginning with advanced age of our patient, presence of diabetes, our overuse of calcium, VDRAs, and the calcium mimetic, or aluminum intoxication. And in early stages of CKD, patient could have BTH resistance, which could end up with low turnover osteoporosis. On the other side, there is an increase in FGF23, which participate in the decreasing of calcitriol level, and it ends up with decreased calcium and phosphate retention and parathyroid hyperplasia, and all of this will lead to high turnover osteoporosis. So how to diagnose osteoporosis? We have many tools for diagnosis or for assessment of bone health in CKD patient, but I would stick to the most common and the most available tools. So DEXA is widely available. I think all of us know about it. And they stated that patient at high risk should be screened, but this high risk is not well defined. When KDIGO defined this high risk, it used the high risk as the general population. And in some literature, they added the long dialysis vintage to this high risk. But I think that the more screening we do is better, even if we don't have a very clear guidelines about it. And one thing to consider if you are doing DEXA is this: BMD values could be falsely higher in CKD patient. If this patient have vascular calcification, especially in the aorta, which is very common in CKD patient, you could have falsely higher values of BMD, especially at lumbar spine. So I would recommend two tools we can use with the DEXA machine. One of them is trabecular bone score. I think Professor Amr Hussein talked about it yesterday. And the long story short, it can give you a hint about the trabecular separation of the vertebrae, about the bone quality of the vertebrae. So you could have the same BMD, but you could have very low trabecular bone score. It is just a program used an algorithm, and the DEXA machine can calculate it automatically. I don't ask about it in Egypt, but I think if we ask the technician about it, they should have it. And it was approved by FDA in 2012. The next is vertebral fracture assessment. Vertebral fracture are very common. They are even higher than the hip and wrist fracture in all age distribution in CKD. And they are silent fracture. And the good thing is you don't have there is no added cost. You just have to reposition the patient to the lateral position while he's doing DEXA. So you can see if he has, if this patient has any vertebral fracture, and with the same image, you could have take a look at the abdominal aorta to see if this patient has vascular calcification. And the next is you can use more of FRAX score using the femoral neck BMD in the FRAX. So you can use the FRAX score without BMD or with BMD, but I would recommend that using it with BMD is better. The next important tool is bone turnover marker. Bone turnover marker can assist turnover and they can monitor treatment as well. We should be aware of that many of them cleared by the kidney, but we have bone-specific alkaline phosphatase, intact B1NB as bone formation marker, and we have TRAB5B as bone resorption marker. They are reliable in CKD because they are not cleared by the kidney, and of course, in addition to the BTH. So you can assess the turnover of the patient, the turnover status of the patient using this biomarker, and also you can monitor the treatment with them. If you are giving this patient a medication to stop the bone resorption, so you would anticipate that these markers will go down. And if you are giving him a treatment to build up his bones, you would anticipate that the formation marker is going up. And the good thing is you can monitor these markers every 3 months. You don't have to wait 1 year as the DEXA scan to have a change in the result. Third is the bone biopsy. It is a gold standard for renal osteodystrophy. It gives you a very good information about turnover and mineralization and volume. And also the bone specimen can be used in FTIR to assess bone quality in micro-CT and MRI. And there are other diagnostics like QCT and HRBQCT. So how to treat? We we said that we have low turnover osteoporosis and high turnover osteoporosis, but both of them. So if you have low turnover osteoporosis, you can give this patient osteoanabolics to help him increase his bone formation, to build up bone. If the patient has high turnover osteoporosis, you could begin with antiresorptive to stop the resorption. And both categories could benefit from non-pharmacological intervention and CKD-MBD management. If you consider it as a pyramid, so the base of the pyramid would be the non-pharmacological intervention. We usually miss those interventions as a physician, but balanced diet, stopping smoking and limiting alcohol, weight-bearing exercise such as walking or running, and the measures to prevent falls, or this non-pharmacological intervention, they are easy, they are no cost added to the patient, and they are effective. And the first step after the non-pharmacological intervention would be the CKD-MBD management, as Dr. Abdalbary said in his lecture. We can use the calcium, the phosphorus-lowering therapies, the vitamin D and the VDRA, the calcium mimetic to achieve the best as we could of CKD-MBD management. Next to this, in some selected patients who would need antiresorptive or anabolics. So in antiresorptive, we have bisphosphonates, the most common, Denosumab, and selective estrogen receptor modulator. On the other side, we have, for the anabolics, we have teriparatide and abaloparatide, and recently the romosozumab. Parathyroidectomy could be used in refractory cases of hyperparathyroid bone disease. If we want to talk about antiresorptive, I know this figure is a bit complex, but we will talk only about the most common drugs. So here is the osteocyte. You can consider this as the bone. Here is the osteoblast, and here is one of the osteoclast. So the bisphosphonate, they act by inhibiting the osteoclast and inhibiting the osteoclast precursor. For the denosumab act on what's called the rank L. So we have the rank and rank L pathway. When the rank L, it is receptor activator nuclear kappa beta ligand. When it attaches to its receptor, it stimulates the precursor of osteoclast and it causes bone resorption. So the denosumab is act as an antibody to the rank L, preventing it from attachment to rank, so it stops the osteoclast maturation and function. The serum can stimulate what's called the OPG, and the OPG is the osteoprotegrin. It is an inhibitor of the rank L, so it can inhibit the bone resorption. On the other side, we have the BTH and the BTH-related peptide, which is the teriparatide and the abaloparatide. They can stimulate bone formation. And we have sclerostin blocking antibody, which is romosozumab. So sclerostin is a negative inhibitor of the Wnt pathway. The Wnt pathway is causing bone formation. So if we block the sclerostin, so we are increasing the bone formation. So bisphosphonates, there are like 3 generations of bisphosphonates. The second and the third generation are most common now. They are nitrogen. They are called nitrogen-based bisphosphonate. Bisphosphonates are available in many forms, like oral and IV, and in various doses from daily dose to weekly to every 3 months or yearly dose. It depends on which bisphosphonate you will use. But we have a concern that they are excreted by the kidney. So dose adjustment, either by decreasing dose or decreasing frequency, may improve bone health without causing damage. But this requires more clinical data for validation. We know that bisphosphonates are effective. They decrease fracture risk in CKD patients in most studies. But we have some concern. We have the non-concern, like they cause some GIT upset, the concern about typical fractures, especially on long bone, the osteonecrosis of the jaw. So you should ask your patient for any plans of dental procedures such as tooth extraction or implant. And we have a major concern of adynamic bone disease because bisphosphonates, they stay in bone for a very long time and they could predispose adynamic bone disease, especially when you use them for very long duration. Recently, the CKD-MBD working group of the ERA-EDTA, they published in the Kidney International Review, they want to say that we could use bisphosphonate more liberally in CKD patient without without fearing the adynamic bone disease, because they said there is no evidence that they could harm our patient. And I had the honor to participate with Professor Amr Husseini and our colleague Subh and Dr. Nahal to write a letter to the editor as regards this review, that the absence of evidence of harm in the study is not equal to the absence of harm. So we don't have evidence that they would cause harm in patients with adynamic bone disease, but this is because we don't have a good study to answer this question. And I would recommend that you read this review and the letter to the editor and the commentary by Susan Ott and Dr. Malik about it. So the second is Denosumab. As we said, Denosumab is a monoclonal antibody to RANKL. Dose of Denosumab is subcutaneous, 60 milligram once every 6 months. But I think it is important here to say that it is not a fixed dose for every patient. The best is to monitor bone turnover marker, DEXA scan, and adjust the doses interval according to it. So in the bone clinic here, for example, they could give Prolia in some patient yearly, they could give it in some patient every 2 years. So according to the level of BTMs and according to the DEXA scan of the patient, you could space the doses of Denosumab. How it differs from bisphosphonate? It doesn't become embedded within the bone tissue. It binds the RANKL in the extracellular fluid, so it could be cleared from the bloodstream with a half-life of approximately 26 days. It seems to be safer in patients with advanced stage of CKD, but we have some side effect and concern as well. First, it inhibits the RANKL, which is immune system modulator, so you should be aware of infection. We have the same concern with atypical fracture, osteonecrosis of the jaw, but they could be less than bisphosphonate. And we have a concern of hypocalcemia because the blockage of RANKL prevents the osteoclast resorption of the bone. This could impair the BTH driving maintenance of the serum calcium. And it is very important to be aware of bone loss after discontinuing of Denosumab. So there is a good evidence from the studies that after the patient stopped Denosumab, the BMD of them, their BMD could worsen at a very high rate. So after stopping Denosumab, you should follow patient DEXA, and it could be a better option to start him on another anti-osteoporotic medication if he needs one. The next is a selective estrogen receptor modulator. They interact with estrogen receptor in different tissue, and we have the raloxifene and the bezadoxifene. They have high estrogen activity in the bone. The dose of raloxifene, it is 60 milligram. It is oral tablet given once daily. And interestingly, there is some evidence that they could improve kidney function, both of raloxifene and the bezadoxifene, but I could say that it is not a very high quality evidence. They are less effective if we compare them to bisphosphonates. So on the other side, if we talk about osteoanabolics, there is a growing evidence now that currently low turnover bone disease is the most common renal osteodystrophy pattern in CKD patient. So we have the teriparatide, which is the recombinant BTH from 1 to 34, and it is daily subcutaneous injection of 20 microgram. But interestingly, 3 times a week of 20 microgram and weekly 6.5 microgram, not available in US, the second one, has shown in some studies that it has similar benefit in hemodialysis patient, and this could improve patient compliance. The second is abaloparatide. It is a synthetic analog of BTH-related peptide, and it binds more selectively to BTH type 1 receptor, so it could favor bone formation with minimizing the effect of prolonged activation, so it could minimize bone resorption and hypercalcemia. So it has a better impact on lumbar spine and femoral neck in patients with eGFR less than 60 in one of the studies. The dose of 80 micrograms subcutaneous, and it is daily injection. And the thing is, we don't have a very good studies on the abaloparatide, so we have only a study of the post hoc analysis of randomized control trial as regards the CKD. There are some side effects and concern as regard teriparatide and abaloparatide. So the first is hypercalcemia and hypercalciuria. Teriparatide can increase BTH level up to 10-fold above baseline before returning to baseline within 4 hours. So if the patient has hypercalcemia or hypercalciuria, you should evaluate this patient for primary hyperbara or any other hypercalcemic disorder. We have the concern of calciphylaxis from some case report, and we have a dose-dependent increased risk of osteosarcoma in rats. This concern limited the use of teriparatide and abaloparatide to 24 months only. But recently, the FDA in 2021 is no longer requiring a black box warning on the label for teriparatide about osteosarcoma. Third one is romosozumab. So romosozumab is a monoclonal antibody against sclerosis. It increases bone formation and reduces bone resorption. It could be given as 210 milligrams subcutaneous every month for 12 months. And we have some studies in mild and moderate CKD and in hemodialysis patient. A recent study from Japan showed that romosozumab could be given in to hemodialysis patient. But we have a very good or a very reasonable concern about increasing vascular calcification. So the romosozumab could increase the Wnt pathway, could stimulate indirectly the Wnt pathway. And the Wnt pathway, it increases the bone formation, and it also could increase the vascular calcification in the patient. And it shouldn't be used in, it shouldn't be initiated in patients who had MI or stroke within the preceding years. In a recent study on hemodialysis, this one was published, I think, 2021, hypocalcemia was the main adverse event. There was no apparent increase in cardiovascular event, but this was only 1 year study, and there is no measurement of vascular calcification in this study. So our take-home message is fracture risk increase with loss of kidney function. In the stage kidney disease, they have up to 6-fold increase in fracture risk. The pathogenesis is multifactorial, but early screening was widely available DEXA using lower threshold for T-scores. So instead of using -2.5 and stick to it for starting the treatment, you could start the treatment in a patient with -2. And also with utilizing of TBS and VFA, this could be beneficial. Consider BTH, bone turnover marker, plus or minus bone biopsy to determine the turnover status. Controlling CKD-MBD and the non-pharmacological intervention are two important steps before or at the time of considering bone-specific therapies. Using a precision medicine-based approach of antiresorptive in high turnover bone disease patient and anabolics or osteoanabolics in low turnover bone disease patient, and monitoring treatment with BTMs and DEXA scan. This could achieve the highest efficacy with the best safety profile in patients with CKD. The last is we need further studies, especially on osteoanabolics and CKD. And thank you all for your attention.